everyone, in our last video we discussed about the causes and symptoms of the cervical incompetency. Now we will continue with the treatment options. What are the treatment options we have for the cervical incompetency? Hello doctor. As you discussed last time, you told during pregnancy we can diagnose the cervical incompetency. So what are the treatment options we have if I diagnose it during the pregnancy of second trimester?
So as we said, we can diagnose this condition during pregnancy, as a first pregnancy are coming, or as it can happen in second pregnancy also. If you diagnose this, as I said, we generally diagnose this around 15-16 weeks. Then it depends on how much is the cervix or internal os which is open. Most of the time, if it is a preventive diagnosis, then we know that the cervix is not very much dilated and there's a minimal amount of funneling. In this case, what we do, I will not talk about everything, what can happen. What we do is we suggest them to undergo a procedure called as cervical cerclage, cervical encerclage. So, cervical encerclage is a procedure where we strengthen the cervix by putting external stitches. It's like, you have a building, and if it is, not the walls or pillars are not standing well, so to support it, how you put extra scaffolding to make sure that the structure works. This cervical encerclage is something like that. This can be put vaginally or abdominally also. But when we diagnose it as the first time during pregnancy, we generally prefer to do a vaginal encerclage. And that too, there is a specific procedure called as chirurgical encerclage, which has shown to be very effective in this condition. Considering that in chirurgicals, we will be putting or placing the cervical encerclage very close to the level of internal os or the internal opening, which is actually an abdominal part of the uterus. Because there are two parts of the cervix. One is intravaginal, another one is supravaginal. Intravaginal is what we can see when we do a speculum examination, which is usually 2.5 centimeter long. But there is 1.5-2 centimeter length of the cervix, which is supravaginal, which is not seen in the when you do an internal examination. So when we put a chirurgical stitch, it goes towards the supravaginal part where we are dissecting the vagina, pushing the bladder up and taking a stitch. So by this, we are going very close to the internal os. It's like, if you give an analogy to it, we can stop a flow of water when it comes very close to your door, or you can even stop it very close to a dam which is making this water come out. So when you're putting a stitch very close to the dam, we're making sure that the pressure is not transmitted way down. So the cervix will still again have a good amount of strength, and we generally use a muslin tape or a band. So it gives us a very good strength. Yes, we can also put vaginal stitches like McDonald stitch, but I prefer to put a chirurgical stitch, which has been very, very effective in this condition.
So there are many patients coming for the multiple abortion history. They already aborted in second trimester only, third time. The fourth time she is coming to you for the pre-counseling. So is the treatment differs for them?
Yes, the treatment definitely differs here. So as I said, if the patient has already had a diagnosed cervical incompetence, and if cervical vaginal cerclage was tried and if it has failed, or patient is very apprehensive because they don't want to end up having this previous pregnancy outcome again, then we have a choice of to go for what is called as transabdominal encerclage. Transabdominal encerclage again are of two types. One is which is done before pregnancy, and one which can be done during pregnancy. And again, the approach of putting a cervical encerclage are again two types. We can put a laparoscopically, or we can also do what is called an open method, like what we do as like a cesarean, we open up the abdomen. But we generally prefer to put a laparoscopic encerclage, which is equally effective as an open cerclage, but with lesser amount of infection, pain, bleeding, and needs a lesser amount of time to recover back. So the timing wise, it can be before pregnancy or after pregnancy. The advantage of putting it before pregnancy is that as the patient is not pregnant, so we are causing less harm to the baby by giving the whole procedure, because this procedure is done under general anesthesia, and during pregnancy some medications are contraindicated when you're giving this surgery. Next is, when you're doing all this procedure, they are also at increased risk of having infection, inflammation, which can theoretically sometime lead to complications during pregnancy. And many of our patients do come with other kind of abdominal surgery which would have happened. Suppose they've already had a previous cesarean, hysterotomy, or a myomectomy. Then it makes surgery more difficult when we're trying to do it during pregnancy. It's very safe to do it before pregnancy, and it has the advantage because we are not putting the baby at a risk, and we can do a proper dissection, not bothering about the time and the injury to the baby. Because in this procedure it involves reflection of the bladder UV fold, and then putting the stitch as close or just around the internal os. After the surgery, we generally say take a break of 1 or 2 months, and so that by then the stitch is more mature, and they can try conceiving after 1 or 2 months. No harm conceiving immediately next month because we have the stitch in place, so it's not an issue. But just to, because they undergo the procedure, the stress and recovery time, we advise them for 1 or 2 months of break. We have not had any loosening of the thread or it coming out and leading on to again an abortion in our series of cases which we have done, because we take certain precautions to make sure that the stitches don't open up. And what is the follow up of this patient once they conceive? The follow up is same. 11 to 13 weeks, we do the scan, look at the cervical length, again call them between 14, 16 weeks, look at the cervical length and look at the stitch. Stitch can be very nicely seen when we do an ultrasound, particularly transvaginal. Many of our patients say that, how will you make sure that the stitch is still there? Because we can show you during a scan where the stitch is and whether it is loose or strong. Yeah.
So there are many myths. The basic myth about this is patients are asking like permanently they want bed rest until the delivery. If you put stitch, after that they have to be in a bed rest until the delivery and what?
Okay, so this is another biggest myth, because many of our patients come and say, see, I'm all fine now, but after the stitch, then I'm advised for complete bed rest. This is what my parents, my relatives, or my even neighbors are telling. That's again the biggest myth. It's like, if you meet with an accident or something, then you are advised certain protection, right? So, though helmet is a norm in our country, but many people don't wear a helmet and then go have an accident and then say, okay, fine, things like that. Similarly, after putting a helmet, would you want to go out, or you just want to sit at home and say, okay, listen, because there is a risk of an accident? No, no. So, cervical stitch acts like an helmet. We have put a stitch, we have strengthened your cervix. You need to be regular. I would not say do lots of exercise, jump around and things like that, or undertake certain riskier job or travel. But you should continue to be normal. Do your normal daily routine work of walking and doing your household work. You can go to your work also, but avoid certain high risk jobs like too much of traveling, too much of jumping, too much of running. Walking is safe and advisable. So after the stitch, it is norm that you need to follow a normal routine, because that improves the pregnancy outcome.
If you put a stitch, they may not be able to conceive the next. That's some question, some patient question. Is that true, sir?
Well, see, when we put a stitch before pregnancy, we're making sure that the cervix is not really tight. We are not completely making a airtight or a watertight kind of a closure here. We generally leave a very small space equivalent to that of your, refill of your pen, like Reynolds pen or anything. So that much amount of space is left, because you need to have your periods. Okay, you need to make, because if you make it very tight, then yes, your blood is not the period blood is not flowing out, and then it can cause all sorts of infection and pain and things. So we need to leave a small amount of space. Next, we leave amount of space good enough so that the sperms are also able to get into the uterus and tube. So this is not a reason for difficulty to conceive or infertility. So we take all the precautions to make sure that it is not too tight nor too loose.
Next question is, many patients say open surgery is better than the laparoscopic surgery. Is it true, sir?
That is the biggest one of the misconceptions which you have, that the open surgery is better than the lab. Thinking that okay, in open we have a direct access and we should be able to provide a better closure, but no, because open makes it also difficult to reach the uterus at that depth and the level, because there is a bony projection there, so it makes the things a little bit more difficult. But in lab, there are so many advantages. One, it is minimally invasive. So we have only some 3 or 4 holes of 0.5 mm. We don't even use 10 mm scope here. 5 mm scope is more than. So the recovery. If I do it in the morning, by evening you're all up and about and walking, and probably next day you can go back to your work also. Next is the chance of infection. The chance of bleeding is very less, and you can definitely try conceiving next month itself, because the incisions are so small. What if you do open surgery? We have around 3 or 4 centimeter long incision, or maybe sometime we may have to extend if it is not very accessible. So then it takes a longer time for physically for you to recover, right? So it is not advisable. Next is the putting the stitch in the when we, that's the most challenging part. Considering laparoscope, we have a good magnification, and we can also know as to where exactly we are putting, and we, with a good experienced surgeon, he can put a definitely a better knot, or he or she can put a definitely a better amount of knots than what we do it, and probably better than the open surgery we can put the knots. So I don't think open is should be given a choice at all to the patient. Probably it's a injustice to the patient if you say do an open procedure, right? So because so much of complications, so much of what do you say, missed opportunities are there. The best option is to do a laparoscopic trans abdominal encirclement. I think we have answered few of the misconceptions about the treatment about laparoscopic encirclage or cervical encirclage to prevent the unfortunate events. If there are any more queries or questions, please follow us and write to us. Thank you.